The study primarily is focused on the COVID-19 and QTC prolongation. And we wonder if there's a need for routine ECG screening and measurement of QTC interval. The first part of this presentation, I will talk about some aspects of normal QT interval, and then later go on to our experience with QT interval in COVID patients admitted in our hospital. Normal QT interval in patients with sinus rhythm is measured from the beginning of the QRS complex to the end of the T wave. QT interval is an electrocardiographic manifestation of ventricular depolarization and repolarization. This is how it is measured from the beginning of Q wave and to the end of the T wave. The problem arises sometimes when there is U wave. So this is what is recommended, that we don't include the U wave, but measure the T wave and consistently do in all ECGs in the same patient and in all patients. Although it is standard practice to measure the QT interval from the beginning of the QRS complex to the end of the T wave, the actual methods of measurement have not been quite standardized. But that is generally, all of us do that. This is the practice pretty much all over the world. Because the QT interval is prolonged at slower heart rates and shortened at faster heart rates, many formulae have been proposed to adjust for these variations. One of the commonly used formulas is the Bassett formula, in which the QT interval is adjusted for heart rate by dividing it by the square root of the RR interval. Other formulae are also available, which take into account some other correction factors, taking the cube root correction, and the other one more which takes into account the linear regression equation. Here are some of the well-known definition and the risks of long QTC. Long QTC can be congenital and acquired, and they predispose to functional re-entry, torsade point, a very serious arrhythmia, and sudden death. Even modest QTC prolongation is associated with an increased risk of cardiovascular events, stroke, and all-cause mortality, often independent of traditional risk factors in a variety of patient populations. Here are some of the aspects of normal and abnormal QTC. Abnormal QTC is defined as a value over 450 milliseconds in males and over 460 milliseconds in females, measured preferably in lead 2 or V5 on a standard 12-lead ECG. Note that females have a longer QT interval than males. And this measurement and this value has been widely accepted, is easily measured, and is considered a risk factor for adverse outcomes. Long QTC, as I mentioned earlier, predisposes to functional re-entry, torsade points, and sudden death. An otherwise unexplained baseline QTc greater than 500 milliseconds should prompt clinical suspicion for the possible presence of a potentially lethal, highly treatable condition known as congenital long QT interval. Acute QTc increases, that is, greater than 60 milliseconds at a given time, are indicative of the exaggerated QTc response that accompanies increased risk of Torsades de Pointes leading to sudden death in drug-induced long QT. Now, what's the mechanism of QT prolongation? There are intracellular changes within the myocyte. The rapid inflow of positively charged ions, sodium and calcium, which result in normal myocardial depolarization. When this inflow is exceeded by outflow of potassium ions, myocardial repolarization occurs. Malfunction of ion channels leads to an intracellular excess of positively charged ions by way of an inadequate outflow of potassium ions or excess inflow of sodium ions. This intracellular excess of positively charged ions extends ventricular repolarization and results in QT interval prolongation. Now here I will briefly talk about Torsades de Pointes, which is actually means twisting of points. It can be congenital and acquired and is related to, it's a kind of a functional re-entry and is well known that patients can have sudden cardiac death due to this arrhythmias. This is a specific form of polymorphic ventricular tachycardia in patients with a long QT interval. It is characterized by rapid, irregular QRS complexes which appear to be twisting around the electrocardiogram baseline. This arrhythmia may cease spontaneously or degenerate into ventricular fibrillation. This arrhythmia causes significant hemodynamic compromise and often death. Diagnosis is by ECG. Treatment is with magnesium, measures to shorten QT interval, and direct current cardioversion when ventricular fibrillation is present. This is twisting of points. As you can see here, this is going up, these are going down, this is going up. So these are really twisting around this central line here. Now, briefly, what's the difference between a polymorphic tachycardia and Torsades de Pointes? All polymorphic tachycardias are not Torsades. The accepted definition is as follows. Polymorphic tachycardia, defined as ventricular tachycardia with varying QRS amplitude. This is commonly referred to as Torsades de Pointes, but it is actually not the same thing. Polymorphic tachycardia may be caused by several etiologies, for example, congenital QT prolongation, acquired QT prolongation, ischemia, Takotsubo-cardiomyopathy. Torsades is defined as the combination of polymorphic ventricular tachycardia plus a prolonged QT interval. Torsades can be caused by either congenital long QT syndrome or acquired long QT syndrome due to electrolyte abnormalities or medications. The vast majority of torsades results from acquired long QT syndrome, which is was the focus of this chapter actually. Now, based on the opinions, the QT interval should be measured manually, preferably by using one of the limb leads that best shows the end of the T wave on a 12-lead ECG. The QT interval should be measured from the beginning of the QRS complex to the end of the T wave and averaged over 3 to 5 beats. The QT interval should be measured during peak plasma concentration of a QT prolonging medication. This is important to note. The QT interval should be adjusted for heart rate. Depending on the length of the episode and whether torsades degenerates into ventricular fibrillation, clinical presentations include syncope or presyncope, seizure. Of note, many times this is not recognized because it is not made aware of. Cardiac arrest. Telemetry monitoring during an episode makes the diagnosis more straightforward. Risks of QTC prolongation. Multiple lines of evidence suggest that modest QTC prolongation in middle-aged and older adults may serve as an early marker for serious cardiovascular events and death. Although the precise mechanisms underlying this phenomenon remains unclear, consistent monitoring of the QTC throughout an individual's lifespan, akin to existing vital signs, may enhance existing risk stratification strategies and aid in the identification of a high-risk subset of patients that requires closer scrutiny for evidence of subclinical cardiovascular disease. I will now move on to COVID-19 and angiotensin system and QT interval. COVID-19 has a high risk of death due to respiratory and cardiac complications. Internalization of the virus or its particles or virus products in the heart may derange myocyte functions such as repolarization, manifesting as QT prolongation on surface ECG. Long QT, as we all know, is associated with cardiac arrhythmias, including sudden arrhythmic death. Previous studies of corrected QTC in COVID-19 have not controlled for other QTC prolonging comorbidities. Our study investigates whether COVID-19 is associated with prolonged QTC independent of other causes of QTC prolongation. Here is some information I like to share with you. Some of the studies, including a study of mine, uh, in which I studied renin-angiotensin gene polymorphism in renal patients. We found that polymorphisms of ACE gene and AT1 receptor genes had long QTC. And these patients, we thought, actually proposed that patients with these genes are likely to have higher prevalence of renin-angiotensin related complications. Then a year later, one more study appeared. They studied ACE gene insertion allele and found that this was a high risk for cardiovascular disease complications. Their study was not focused on the renal studies and or any other systemic disease. There's one more study I came across, and this is of great interest, that ACE inhibitors have a protective effect on some viral diseases such as leishmaniasis. The exact mechanism of this is unclear, but I think this is interesting that renin-angiotensin system related drugs have some have a very serious effect, some have a beneficial effect on some diseases. I show this picture with the interaction of COVID-19 and renin-angiotensin system. As you know, this has been very controversial, but there are more studies to show that with COVID-19 infection, renin-angiotensin system is upregulated because COVID-19 somehow has such an effect which spares the degradation of these renin-angiotensin products. As a result, there can be greater side effects, or there'll be more effects due to the renin-angiotensin stimulation. So the point I'm making is that RAS is probably upregulated, and that, along with my own work and the work from a couple other labs, the renin-angiotensin system, if it is stimulated, it can prolong QT interval. Now, the possible mechanisms, how the virus enters is unclear, but the possibilities are that somewhere, somehow, some products of this virus, they interact directly with the repolarizing channels, interaction of circulating viral particles with the myocyte, release of products which interact with repolarizing channels, and direct effect of RAS active product, circulating angiotensin on repolarizing channels. So in the present study, we took QTC values, actually we measured them ourselves, were taken from ECGs of 36 patients with patients admitted to intensive care unit and compared with 70 healthy age and gender matched control subjects. Patients were excluded who were on QTC prolonging drugs, had hypokalemia, hypocalcemia, hypomagnesemia, or history of alcohol excess. QTC values were taken from 36 patients and 70 healthy adults. Actually, move on to the next slide here. The results are here in this table. In male, 465 patients, controls 416, females 475, controls 425. As you can see, difference between the males and the females. Females had longer QTC. The total was almost 469, 470, control 418. All values were highly significant. This is a graphic representation of what I just said. The control values are here, and here is all combined males and females, COVID-19 patients. So as you can see, there was few patients in this group had hypertension and few had diabetes mellitus. Electrolytes were normal in the patients we studied. Potassium 3.97, magnesium 2.4, calcium was also normal. And as I showed earlier, QTC was prolonged in males and females with COVID-19 patients. So in conclusion, I would like to say that COVID-19 alone, without an associated QT prolonging etiology, is associated with QTC prolongation. Ventricular arrhythmias may be more likely to affect women with COVID-19 than men with the disease. Therefore, it is recommended that in COVID-19 patients, electrolytes be maintained within normal limits and QT prolonging drugs be avoided. Thank you for your attention.